Okay, good morning, everybody. Today it's my honor and privilege to introduce our visiting professor, Dr. Gelareh Zadeh, who's joining us from Toronto. She joins us this morning as a 2021 Andrew Connell Curtis endowed speaker, which is a speaker series that's really just focused on brain tumor accomplishments and brain tumor research. And as you can see from some of the past speakers, really have some amazing world-renowned speakers over the last 5 years, and there's no doubt that this year will top that. And so we're very excited to have her join us. If you don't know her, or if you missed last year's, she was one of our honored speakers on our Miami Global Brain Tumor Symposium. But if you missed that and you don't know who she is, Dr. Zadeh is the family chair of the Dan Family Chair of the Division of Neurosurgery at the University of Toronto. She's a professor and senior scientist in neurosurgery there. She's the head of the Division of Neurosurgery at the University Health Network, co-director of the Brain Tumor Institute, and Wilkins Family Chair of the Brain Tumor Research Center. Also, she's president of the Society of Neuro-Oncology, and we'll be hosting again this year's meeting in Boston, and editor-in-chief of Neuro-Oncology Advances. So very, very busy schedule, and we thank her for joining us on Zoom. We wish it could be in person to spend time with us this morning and also this afternoon with the residents.
Great, Michael, thank you so much. I also wish that I was there in person. I was really looking forward to this trip and my tickets were booked, but unfortunately with the increasing variants, our institution actually recommends against travel at this point. So I hope that I can have each of you up to Toronto to visit. There's a lot of alumni also, and I just saw Dr. Alan Levy. I have a funny story, if time permits, about Dr. Alan Levy and myself in the American board exam, but I will tell you at the conclusion of the talk.
There'll definitely be time for that, don't worry.
Let's not do that. Thank you for coming. Even if it's virtual, we really appreciate it.
Thank you. So I was asked to do 2 clinical talks. One, I thought I would focus on what my practice is, which is skull-based, and mainly on our results for pituitary tumor surgery. And again, if time permits in this hour for the clinical presentation, I'd like to show you some of the results of a clinical trial that we've done and be able to discuss some of the lessons learned as a surgeon conducting clinical trials. I have no conflicts and no disclosures other than, as Dr. Ivan said, I'm the president of Society of Neuro-Oncology and the editor-in-chief for Neuro-Oncology Advances. These are the range of tumors that we deal with in our practice in neuro-oncology, and you're familiar with them. We focus a lot of our time on glioblastoma and understanding its biology so that we can improve patients' outcomes, which unfortunately remains very poor. An area that's interesting for me to focus on is meningiomas, in part due to my clinical practice and interest, and also because we understand the biology of these tumors very little. But today, this morning, I'd like to talk to you about pituitary tumors, where we do these tumors now at our place purely endoscopically, as with most centers, but I'm not a surgeon that's committed to one approach versus the other. I do think a lot always depends on the comfort of the surgeon, their experience, and their own choices. However, all of our pituitary tumors are done endoscopically now. And I have to say, should we choose to do an open case, I'm not sure that I'd know where the instrumentation is held in our hospital. So this is a very broad overview of pituitary tumors that we get. There's various forms that are functional with secretion of growth hormone, prolactin, and in the case of corticotrophs for Cushing's. However, majority of them do remain silent in that they are not functional, but due to their size, create considerable concern with regards to neurological structural compression and also mass effect itself. We had wanted to review our endoscopic experience because, as I said, my senior colleague, Fred Gentili, who I have to give credit to for training and mentoring me to be able to do these cases, and I do all of our endoscopic cases, and we wanted to see what our outcomes are compared to our open tumor surgery, but in general report complications that are associated with this. Much like all other clinical reports, ours is similarly also limited in this way. The language that we use to report metrics of outcome vary between different studies. And if you look at the literature, these are older, however, even more recent. We typically are not able to, for a variety of reasons, though all of us recognize the importance of it, reach agreed upon terminology on how we define outcome and metrics and endpoints, and what, for example, is complete resection, what's gross total resection, et cetera. Whether in fact, just simply we measure tumors linearly versus volumetrically. So the language varies in the literature, and as a consequence, the gross total resection varies anywhere from 47% to 9.6%. And I should specify, if I didn't, that this is the literature specifically on pituitary macroadenomas, which by definition are greater than 3 centimeters. Some reported as percentage, varying between 63 to 93%. Some report visual outcome, some don't report visual outcome, and recurrence rates vary depending on the length of follow-up that each study has. Nevertheless, I think it's important that institutionally we review in a retrospective manner databases that are collected prospectively to ensure that our standards are to those of others in the field and to also learn from our own experiences. So we reviewed approximately 600 cases that we had operated on transsphenoidal for pituitary adenomas, and we identified those that were macroadenomas by definition greater than 3 centimeters in any of its diameters, or the tumor volume is greater than 10 centimeters square. We then looked at parameters pre and post-operatively with clinical demographics, laboratory investigations, MR imaging characteristics, tumor volumetric analysis. For pituitary tumors in particular, linear measurement is quite challenging to reflect the actual size of the tumor. And so we used freeware that was available to do volumetric analysis. And we looked at our tumor pathology, and we're fortunate to have had a very dedicated clinician scientist as a neuropathologist, well recognized, Sylvia Eza, who reports on all growth factors for all of our pituitaries. And we were able to see whether this correlated to the pattern of growth invasion and determine extent of resection as a prognostic indicator, for example, for our patients. For our outcome, we looked at extent of resection, again, looking at volumetric measurements. We looked at visual changes based on acuity and visual fields for all the patients we had the data on, endocrine function, and other complications postoperatively related to the surgical intervention specifically. We did multivariate and univariate analysis that predicted the extent of resection with the goal that perhaps we could identify clinical and imaging factors preoperatively that would allow us to counsel the patient and also make decisions more accurately for recommending surgery. We used linear regression model to assess the relationship between the various factors that I mentioned, extent of resection, and continuous independent variables to identify predictive markers. Of the approximate 600 cases, we had a total of 73 that met the criteria and we had sufficient follow-up on. Male to female ratio was 2 to 1. The hemorrhagic component that was evident on MR preoperatively was present in approximately 25% of the cases, and 8% had apoplexy. Sphenoid sinus invasion was evident in 35% of the cases, suprasellar extension, as predicted, almost in 100% of the cases, but not all of them. Anterior extension towards the frontal cranial fossa in 16% of the cases, posterior extension in 31% of the cases, and lateral extension beyond the cavernous sinus and carotids, 26% of the cases. Hydrocephalus was present in 5% of the cases. 16% of our patients had had a prior surgery at another institution. 4% had had radiation previously. In Toronto, we're very conservative with recommendation for radiation for our pituitary population, in particular preoperatively, but also postoperatively. As expected, due to the suprasellar extension, majority had optic nerve compression. 57% had a decline in visual acuity pre-op. 45% had visual field deficits pre-op. Surprisingly, this number is lower than I had anticipated. Ophthalmoplegia was present in 10% of the cases, and the average tumor volume based on the software that I showed you that we used was 18.5 centimeter cube, and the range was between 10 to 75 centimeter cube. We did this with 3 different readers, and the inter-observer consistency was very high and accurate. The average diameter of the tumor on linear measurement to make sure that our language matched other past reports was 4 centimeters with a range of 3 to 8 centimeters. Visual outcomes postoperatively, acuity, we had 75% improvement, 4% worsening, 6% had no change, and approximately 16% had no pre or post-op deficits. The fields improved in 61% of the cases, 5% had no change, and 32% had no pre or post-op deficits. Endocrine outcome, a single axis is 7%. Within the single axis was also considered thyroid deficiencies, which is always challenging to directly ascribe to pituitary tumors. Panhypopit after the surgery is 3.8%. The other matters that we looked at is sinusitis in 14%, CSF leak in 9%, which all resolved with a lumbar drain, diabetes insipidus in 4%, meningitis in 2.7%, hydrocephalus in 2.7%. On the point of the CSF leak, a historical important note, and I think majority of you are familiar with this experience. When we first started doing endoscopic pituitary tumor surgery resection, in fact, I was a senior resident training with Fred Gentili, and the leak rate was extremely high. The factor that made a big difference in all of our practices for endoscopic cases is, of course, the nasoseptal flap. And routinely now, we do have a nasoseptal flap for all of our endoscopic cases. You could argue that not all of them require a nasoseptal flap. However, the educational component of being able to create an endoscopic nasoseptal flap is important as well. The patients that required reoperation, 7 of them, so bringing that to approximately 10%. Postoperative radiation, 6% in 6 patients, which is 8%. At the time that we sent this for publication, a reviewer asked, well, what is the rate of apoplexy post-op for giant pituitary macroadenomas, recognizing that that is a complication. And for this series, in fact, we had none. However, while I was writing the response to the reviewers, I operated on a pituitary macroadenoma with an extreme extension suprasellar. A small portion of the tumor was left behind, and in fact, the patient had an apoplectic event and bled. So from that, I learned an important lesson, and that is a genuine complication, and I have to thank our reviewer for having made that comment to us. In other words, reviewers are not always bad, and they're trying to help you with your publications. So we looked at the post and pre-op imaging, as I mentioned, volumetrically. Gross total resection is 25%. Near total resection, which we would expect and define by greater than 90%, we saw in 16.7%. Subtotal resection is defined by 70 to 90% resection in 36.4%, and partial resection, less than 70% resection, we saw in 22%. So since that time, of course, it would be interesting, a follow-up to look to see, depending on the extent of resection, what is the longer-term outcome following tumor resection? This is an example of a case where clearly there's a hemorrhagic component, a solid component, and post-op there is a residual, but we would categorize this as a near total resection. We look then to see at the correlation of the volume with the extent of resection. Excuse me, for those who we were able to achieve gross total resection, the volume was 16.2 centimeter cube. For those that we were able to achieve a greater than 90% resection, The cutoff was approximately 15 centimeter cube. 70 to 80%, the cutoff was 18.9%, centimeter cube, and less than 70%, the volume was approximately 22 centimeter cube. As you expected, the bigger the tumor becomes, the less possibility we had for resection of that tumor. We then looked at the predictors for extent of resection, again, helping us as surgeons in preoperative determination, more importantly, with counseling of the patient for expectations postoperatively as well, and to also understand perhaps whether certain anatomical extensions are more favorable than others beyond what our general feeling is as surgeons. The maximum tumor diameter was significant as expected. The preoperative tumor volume was significant. The hemorrhagic component was not significant. However, this may be a statistical factor as there was not a significant number of tumors that started out with a hemorrhagic component. Sphenoid sinus invasion, interestingly, was not significant. Posterior extension, however, was significant, and the NOSP grade were in the reverse of correlation to extent of resection. Lateral intracranial extension approached significance, but didn't reach significance. And that, again, I think is a statistical power issue for the numbers that we looked at. The parameters that did not come significant in our analysis were preoperative visual field changes or acuity, apoplexy, prior surgery, prior radiation, or prior medical therapy. And this really pertains to the few that we had with growth hormone and prolactin that were not responsive to treatment. Presence or absence of hydrocephalus, as I mentioned in the last slide, the anterior extension and lateral extension did not reach significance, and the optic nerve compression nor the surgeon. The surgeons were myself and Fred Gentili. We also looked at the tumor characteristics that were reported on our neuropathology reports, which, as I mentioned, typically and at our place, but this is not characteristic of all, we have reports of the cell type, cell functional status, and tumor markers, looking at P27 in particular and FGFR4, which are known factors to regulate pituitary tumor growth in the literature, and none of them correlated to the extent of growth, pattern of growth, and more importantly, outcome following surgery. So that is our surgical experience. The question is, are there biological factors? And as a surgeon, I am very certain that the consistency of the tumor is a reflection of the biology of the tumor. There are pituitary gonadotrophs that you find are sticky, are very difficult to resect completely. There are gonadotrophs that are extremely soft and suckable. Majority of them are. But there has to be something specific about the biology of the tumor. And we know as surgeons that if the tumor is very invasive while you're standing in the OR, likely your pathologist will give you one of the rarer type of invasive pituitary subtypes. What are some of the factors that may help us understand the biology of the tumor, more importantly, predict outcome for the patients, and in particular for pituitary tumors, really the question for the patient postoperatively is what is the chances of recurrence? And in more giant pituitary macroadenomas, the question remains which one of them would benefit from additional radiation upfront early versus a surveillance model postoperatively. The factors in the literature that we could summarize biologically help direct the growth of pituitary tumors are not unexpectedly cell cycle dysregulation, growth signal imbalance, factors such as cancer stem cells that people have focused on identifying in pituitary tumors, whether it's a factor of hypothalamic hyperstimulation, atypical microRNA expression, and aberrant epigenetic regulation. And I'd like to focus a little bit on this for this talk and also my subsequent talk. If we look at the WHO classification, you could see that there's over 150 distinct different brain tumor types. And this is all based on histopathology. However, over the last 2 decades, the tumor that we have studied the most, which are gliomas, due to their poor outcome, we've evolved from defining them based on histopathology and include within our definition of the tumor and understanding of its biology, growth factor, and more importantly, mutational signatures, with the key determining mutational signature for gliomas being IDH mutation. And so we look at gliomas very differently, moving away from what's a astrocytoma, oligoastrocytoma, oligodendritic glioma, as it was defined 20 years ago, to based on whether it's an IDH mutant tumor or an IDH wild type. And then subsequently, whether they have 1p19q loss or they have an ATRX loss, and et cetera, and so forth. And why is this important? Because in fact, each of the subtypes, depending on its IDH status, the 1p19q ends up with very distinct prognostic outcomes, where the low-grade glioma with IDH wild type 1p19q loss has a significantly better outcome compared to the regular glioblastoma with IDH wild type. So can we do a similar study and understand the pituitary tumors based on a mutational signature? There are a few studies. Some are very key studies. I summarize them here, but only to highlight that I think there's a need to understand pituitary tumor biology better, and we need larger scale numbers. A lot of the tumors that we deal with, though for our own practice, populates the majority of our practice, in incidence, the numbers are small. And so in this case, you could see in the study, there was approximately 45 tumors, if I'm not mistaken, that was analyzed by whole exome sequencing. The mutational burden is documented as a heat map, where you could see red is the highest gain of copy number, and blue is the loss of copy number, and also mutations that were identified. You could see that the gonadotrophs, perhaps you could say as expected, are very bland with almost no repeat losses that result in any impact on the heat map. And then based on the various subtypes that you could see here, there are some changes, though not significant. And if you look at the non-functional typical pituitary tumors compared to non-functional atypical and functional, you could see that the burden of genomic disruption is slightly different. However, not the similar story as the IDH mutation of gliomas, where we can depend on one single mutation or a series of recurrent mutations that would define a bad actor from a better prognosticator of a pituitary tumor. A second study similarly looked at, again, the genomic alterations within pituitary tumors. And you could see once again that they define the gonadotrophs and the non-functioning tumors a little bit separately, but there are no recurrent mutations. There are two recurrent mutations that the study identified, and you could see them here, USP8 and GNAS. And these are particularly restricted to, again, the functional tumors, in this case, ACTH secreting tumors and the growth hormone secreting tumors. When you look compared to other cancers, if the tumor in fact is bland genomically, meaning the alterations in the gene copy number is not significant, you compare that to the rest, it's comparatively quiet. And then when you compare it, however, for a disrupted pituitary tumor where the genome is disrupted, so in the subtypes that we pointed out, you could see that it's not different in its degree of disruption from other cancers, arguing perhaps then that this group, based on copy number alterations at least, should alert you to the fact that they would behave more aggressively. These are data that are important, that require further analysis and understanding, and I think worth for us as a community to think of combining results, but more importantly, combining tumor samples to be able to do large-scale research on a tumor such as pituitaries. I also just wanted to quickly show you some of the results that are published, because again, it's relevant to an area of interest for us in the laboratory, and again, you'll see in my second talk, which is to look at the methylation pattern of tumors. In 2018, a seminal paper was published in Nature by the DKFZ group, the oncology group in Heidelberg. They looked at approximately 3,000 different brain tumors from 82 different subtypes, and they analyzed these tumors by methylation. And you could see that the methylation pattern of a variety of tumors is reported, and this is a classifier where you use the methylation signature to be able to determine the subtype of the tumor and the pathological diagnosis accurately. And in their study, they show that there's a 15% accuracy and change in the original diagnosis from histopathology. And there are pituitary tumors included in here for ACTH, for example, where the signature of this tumor is vastly different from the other pituitary tumor types. Similarly, the signature methylation of GBM wild type is different from the GBM IDH mutant. So it's akin to almost a fingerprint for each of our tumors. What do we know specifically of pituitary adenomas with regards to their methylation? There have been a couple of studies with, again, smaller cohorts, however, sufficient data to say that perhaps it warrants additional investigation using methylation to be able to determine biology and outcome of the tumors. This study looked at a number of pituitary adenomas where they looked at the CpG site methylation and looked at the 5,000 most variable probes. And you could see that it divides into 2, possibly 3, based on the heat map. And again, you could see that the inactive gonadotroph or non-functioning pituitary tumors, the methylation pattern is very distinct from the functional tumors. Similarly, another study looked specifically at DNA methylation of particular factors and saw that the DNA methylation levels were very much different in the invasive versus the non-invasive. So these are all very early studies, however, all to say that there is evidence enough based on the publications that the methylation pattern and correlation to the biology of the tumor, whether we look at the functional status and non-functional status of pituitary tumors, whether we look at invasive versus non-invasive, are distinctly different. And we could see that, for example, hypermethylation of the probes, in other words, inactivation of certain genes, is perhaps more frequent in invasive pituitary tumors compared to non-invasive. And so there is sufficient literature and data in publications to say to us that perhaps this is an area that we should investigate further and focus on moving forward. So this was the portion of my presentation focusing on management of pituitary tumors. I just want to have a shout out to our neurosurgery residents. We have 36 residents in our neurosurgery program at University of Toronto. It's really a pleasure for me and an opportunity for me to be interacting with so much young talent. I enjoy working with the residents very much, and they keep me live and younger and current, actually. So it's a great opportunity for me, I have to say. I did want to take a little bit of time to recognize my very dear colleague, Fred Gentili, who, as I mentioned, he is my mentor, my teacher, and subsequently my colleague. The data that I showed you on pituitary tumors, I have to say I credit him for everything that I know for resection of the pituitary tumors and endoscopic cases when we do tuberculum, cellular, olfactory groove meningiomas, and my skull base experience. This is a picture of him from a few months ago. I have his permission and he's happy for me to show this. He was diagnosed himself with glioblastoma. And though the title of my talk is focused on pituitaries, I would like to show you some of the results in recognition of the battle that he's going through with studies that we've done to improve outcome for patients with glioblastoma, and hope that there is hope for Fred, of course, and all of our patients with glioblastoma. A study that I did at University of Toronto, at Toronto Western Hospital, is the study that's called CAPTIVE. It's a study that, in my opinion, is primarily driven by surgeons. And I do think it's important as surgeons, we have an opportunity that on the field, intraoperatively, we actually get involved with clinical trials, and the direction of the trials is very important. This is an adenovirus that was designed by the team at MD Anderson, in particular Fred Lang and Juan Huevo. And we have been the site that has accrued the most number of patients to the study. with injection of the inactivated adenovirus that only recognizes replicating cells, which then creates an immunogenic response, and then followed by pembro. There was a dose escalation study where there were a total of 10 patients included to achieve the most effective dose. And once that was done, we moved on to expansion, which included the DNA tricks plus the pembro. And we looked at endpoints, which is safety, of course, overall response rate. Secondary outcome is overall survival at 12 months and clinical benefit rate. This study was injection of the adenovirus through a very well-defined fine copper cannula that required injection approximately 45 minutes to sometimes an hour and 20 minutes, which was the rate limiting step perhaps for some centers to lose that much OR time as we wait for the pump to gradually inject the adenovirus. In comparison, some of you may be familiar, in parallel and slightly earlier than this study, there was a viral therapeutics with tocogen. The injection of that is done with a needle. And in my experience, as we enrolled in that study as well, the likelihood that you would have return of the material injected into the tumor bed was very high. And I think that's one of the challenges as surgeons, that we can again be at the forefront of identifying strategies that can improve delivery of the virus. The eligibility criteria of the study is, as you could see it, with the most notable being that the tumor would have to be greater than 10 millimeters in 2 perpendicular diameters, however, not greater than 4 centimeters. And we would not recommend resection based on a discussion at our multidisciplinary tumor board. And so the tumor would have to be in some ways intact and not resected. This is at recurrence. The exclusion criteria was whether the patient had multiple lesions, the tumor was not stereotactically accessible, and if they had any prior anti-PD-1, PD-L1 therapeutics, and they were not on Avastin for 4 weeks. This is the range of clinical characteristics of the patient, not unique to this study, and in other words, representative of the average population that have glioblastoma. The IDH mutation status is, as you could see it, representative again, with majority being wild type and approximately 10%, perhaps slightly higher than average, being mutated. MGMT status was documented, again, similar to what we see in an average GBM population. And this is the prior therapies, very standard therapies that all the patients had received prior to the study. These are the duration for which the patient was on treatment. And it's interesting because, as you could see from the dose escalation and then subsequently the stabilization of the 42 patients that we collected, the duration with which the patients tolerated pembro is much higher than previously reported historical numbers. And the thought here is that perhaps the adenovirus itself allows some degree of tolerance to the pembro with regards to how much inflammation it creates, and the pembro actually is helpful in tackling that. The next is we looked at adverse events following the adenovirus injection plus the pembro, and you could see that the adverse events, anything grade 3 or higher, and any grade is overall very tolerable, with the frequency of all adverse events being 35%, brain edema being the maximum. And in my experience, and worth again studying further, patients who had significant edema following the adenovirus injection, in fact, did very well, perhaps suggesting that the adenovirus was able to trigger a strong immune inflammatory reaction, resulting then in a positive response to the pembro. So in other words, it facilitates and enhances the response to the immune therapeutics. Brain edema overall for more than 5% frequency was present in 16%, seizures that were manageable in 12%, hemiparesis in 10%, aphasia in 6%, and headaches in 6%. This is the results, and you could see that it's impressive because in fact, there are 2 patients that continue to have complete response. And one of them is my patient. And I would say to you that previously I would have perhaps thought that there was some mismatch in presentation of the images, which I'll show you, that perhaps did not reflect the accurate course of the patient. But the one patient that we had that was an IDH wild type and responded very favorably and continues to still, many months later, have response, had a complete resolution of the tumor. The partial response and stable disease combined, as you could see, the percentages is, again, historically a very favorable outcome, which is 55%. The complete response and partial response, again, is 12%, all very positive numbers. This is the patient that I was mentioning. He is younger. He has an IDH wild type glioblastoma. The pathology has been reviewed by 3 independent neuropathologists, confirmed by methylation to be IDH wild type glioblastoma. And you could see that following the first recurrence, he was enrolled. And this is the scan, 14 months, and currently remains as such. And this is now 3 years after. And so he has been the one tumor that we perhaps can study further to understand why we have such positive results. Here, I want to thank the group in my laboratory that does majority of the work that I show you today. We have a big group, we have a diverse group, and I'm very proud of them. All of our neurosurgery residents that are in the lab, Farshad Nasiri, Matt, Jeff, and one of them is missing in this picture in particular, are a pleasure to train and have my PhD students with me. So I'll stop here and thank you again for your invitation. Again, I wish I was in person. Obviously, it would be a different flavor to it. Nevertheless, I'm very happy to have the opportunity to spend the day with you. Thank you.
That was a fantastic talk, and I just again wanted to thank you for visiting with us. I know that you had mentioned about your Toronto residence, and you know, I always glow when I hear someone from Toronto speaking, because you know Toronto is always so understated, and I think you know our team should know that it is the largest residency program, when the largest academic program in North America. You know, they publish 1,000 papers a year, which equals like 3 papers a day. And it's just unparalleled. So when I heard you were taking over the lead there, I was very excited. Being old and seeing 5 different chairs, you know, come through in the last 40 plus years with Dr. Hudson, Dr. Tatter, Jim Rutka, Dr. Lozano, and yourself. I mean, it's obviously a great legacy, and you fit that legacy perfectly. I mean, not only a great surgeon and scientist, but you know your administrative abilities have raised you to this level, and we're very excited to see you be the lead there.
That's very kind. Thank you very much.
Yeah, I don't know if there are any questions from your talk from the rest of the group.
Yeah, great talk, Gelareh. This is, again, Mike Ivan. Just going back to some of the pituitary analysis that you did, which was extremely comprehensive. I just wanted to know your thoughts on when we started learning about glioblastoma. We found out that there's so many different mutations within it in different areas of the tumor. And then we went to meningiomas, and we kind of thought, well, meningiomas are much more solid and simple tumors, and the mutations are homogeneous. But most recently, the UCSF group has really kind of started, and I think yourself, looking at different zones of the meningioma. Do you think we're going to eventually find this idea with pituitaries too, that the tumor that's invading the cavernous sinus, invading through the arachnoid, may have some different methylation or you know, genome kind of alterations that are going to be critical compared to just sampling one area of the tumor? Or do you think that this is a more simple tumor and that it's uniform?
Yeah, great. Thank you, Michael, for that question. So the studies that I showed are studies where they've looked at the mutational pattern, and it looks like the gonadotroph non-functioning tumors do not have a recurrent mutation. And so probably this will not be a mutational driven tumor or a mutational story. And I think, again, in the next hour, I'll show you the data on meningiomas. Not dissimilar. It's not based on mutations that you could see these tumorous growths. It appears that the functional tumors perhaps have more mutations, but again, there, the number of recurring mutations don't seem to match. And I think some of the results also are limited by the fact that there are small numbers, and to do the large genome scale studies that we need to better understand the biology, you really need a more cohesive cohort where the same platforms and same analysis are done on the same tumor types. So I think it's an opportunity for us in our field. However, I think it's an area that often, because of its quote unquote benign nature, we then divert our attention to more malignant tumors and more aggressive tumors. But certainly I think there's room for looking at the pituitaries on a larger scale. I think just, again, going based on what we see in meningiomas and glioblastomas and looking at what we're seeing in these initial studies, it won't be a mutational story in that there is no recurrent mutation that defines one pituitary subtype from the other, but rather, as you said, it appears that the methylation perhaps is something, whereas a methylation signature, because it's so conserved, that maybe we can rely on the methylation pattern to be able to make determinations and predictions for outcome and for responsiveness to treatment. The challenge with mutations is, as you said earlier, depending on what region of the tumor you even look at, the mutation pattern may vary. And so the fact that it's recurrent, it's not recurrent, makes it a big challenge because you can't really hang your hat on it and do any studies, use them as markers, etc. So to me, I think the biggest opportunity, if I had the bandwidth, or if anybody in the audience has the bandwidth, would be to accumulate the existing literature, add additional samples, come up with a large cohort of about 300 or 400 pituitaries, and then do methylation and use that epigenetic methylation signature to be able to come up with some predictive modeling and also, again, determination of response to therapies. Because for the very small population of our pituitaries, as you well know, when surgery fails, we're left with very poor options. And though we go to radiation as a de facto, the responses are not that great, and its proximity to the optic nerve and the apparatus is always a challenge in decision-making for this patient population. I don't know if I answered your question.
Yeah, no, that was great. Thanks so much.
Hey, Gelareh, how are you doing?
Great.
Go ahead.
You can go first.
Okay. Nice to see you.
Nice
Carolina here.
Yes.
I was just two questions. Are you guys routinely doing medial cavernous wall resections for the pituitary adenomas, or at least for the functioning ones? And also the other thing was, you mentioned that case where you had the hemorrhage. For some of these giant tumors or multi-compartmental tumors, what are your thoughts in terms of which approach to do, whether you go transcranial, endoscopic? Obviously you're going to go endoscopic, and if there's something that you feel like you need two approaches, what's your timing of your approach to prevent the apoplexy and hemorrhage postoperatively?
Yeah, so on the point of the medial cavernous wall, I personally pursue it to find perhaps an area that it would enter into the cavernous sinus and try to use that same corridor to remove tumor, but I don't pursue it beyond that. In other words, I try to find the area that the invasion would have happened and follow that same path. I don't create a new path. I'm a bit weak at heart of a surgeon. I always joke with the residents and the fellows. However, I do persist. And so I try to find the area that it goes into the cavernous sinus. With regards to that experience, I think if I understand your question correctly, when it is a giant pituitary tumor, a macroadenoma, I make sure that we can get as near a complete resection as possible, because that residual, in my experience following reporting our experience, as the reviewer had said, is that there's a higher chance of apoplexy. And so I really try as best as possible to not leave any residual behind, because the hemorrhagic component will potentially cause harm to the patient. But I'm not, is that what you asked me? I didn't understand the timing question.
I'm saying, like, if you have a tumor that you do feel you're going to need two approaches for, or that you're not going to be able to get a gross total just with the endoscopic approach.
Oh, I see. Yeah, that's
like,
a good
what
question.
Your timing be like?
Yeah, I've not had to do a craniotomy, nor Fred. Maybe in the last 10 years between the two of us, we've decided to do a craniotomy for only 2 macroadenomas we were unable to approach endoscopically. And one of them, in fact, ended up being on the repeat craniotomy surgery. The pathology corrected itself to some rare tumor. And at this moment, I can't remember the subtype it ended up being in. We weren't any better open compared to endoscopic. So that I would say at this stage, our experience is such that we approach majority of our mid-cellar, supracellular lesions, anterior skull base endoscopically. So there isn't a lot of finesse in our decision-making for the pituitary tumors. But we're able to achieve a very good gross total resection. And the data set that I showed you, in fact, again, at this stage, I don't have the bandwidth, but I'll find a student who could go back and look at the same cohort and see what is the longer term consequences of the extent of resection that we have.
Thank you.
My pleasure.
Hi, I'm Heather McRae, one of the pediatric neurosurgeons. I had a question on your glioblastoma work. For that patient that you showed the amazing response on, when you compare that to the other patients where you've seen some response, do you think everything is intrinsic to the biology of the tumor and there's things that are similar between the ones that have responded? Or are there also differences in terms of timing of treatment and other factors that may be at play?
Yeah, that's a super good question. Whether it's the stage at which you catch a glioblastoma, which I truly believe makes a big difference, or, as you said, some inherent biological alterations, and data that I can't really, because it's not finalized and the company has not approved, but the preliminary shows that the extensive inflammatory cell markers expressed in the tumor does not determine response to the treatment. Like I said, my own personal experience has been with this trial. The more inflammatory reaction you can create with injection of the adenovirus, and my impression is that you need more solid tumor to create that sort of a reaction, they then tend to respond better. So this young man that I showed you had an extreme amount of edema that required significant inpatient management with steroids. But then once they were over that hump of the inflammation that it created, they responded very well. A second patient that didn't have complete response, but stable disease, similarly had an extreme amount of edema, require inpatient admission. But I think ultimately it will come down to, as you know, glioblastomas and medulloblastomas have subtypes based on their molecular signatures. I think we will reach a point where we will molecularly characterize the tumors based on their response. So really this precision medicine, it's a question of what is that signature? So what is unique to this guy's tumor? And you could argue that he really falls into the young adolescent group of tumors. He's not one of the midline gliomas, and he didn't have any of the known fusions, but there must be some other factors. However, there were others in the study that responded favorably as well.
Thank you very much. It's neat work.
It's nice to meet you.
Nice to meet you too.
Well, we have a few minutes left, I think. Yeah. Sorry, somebody started to talk.
Just asking any other questions. Anybody has any other questions?
All right. Perhaps if time permits, I could tell you my story with Dr. Alan Levy. He will not know this story, but I will tell the story. I took the oral exam course, and I won't say the name because I don't want to make it seem like I'm promoting it, but I will tell you the story. It was in the hotel room, and I was unfamiliar with the hotel. And for those of you in the audience who know me well, I'm always slightly late, slightly. And I had bought my Starbucks latte, and I arrived in the big auditorium where it was filled with people in the hotel with my latte a few minutes late. And then I hear Dr. Levy say, "Dr. Zade." And I think to myself, really? He's going to make me feel bad for coming in late? And you said, "Please come to the podium." I'm like, come on, I was just a few minutes late. This is all in my head. I walk up to the podium and Dr. Levy says, "Please have a seat." I'm like, this is really crazy. I mean, this is excessive. I'm just a few minutes late. And then I sit on the seat and you put up a case and I go, "Oh," and you say you are on the hot seat. I'm like, "Oh, I guess I signed up for this." And you show me a case and I say, "Well, I would do conservative management. It was a small disc. I wouldn't operate." And you said, "Dr. Zade, this is the states everybody operates. That's your answer in the exam." Whereas in our Canadian exam, we would never operate on that disc and we would fail the station should we operate. So it was just an interesting nuance.
That I didn't know. That's pretty funny. I don't actually remember the case, but I'm glad you attended the Goodman course.
Right.
I'm going to put a plug for it. And again, great job that you're doing in Toronto.
Thank you. And thank you for all the residents that you do take from our graduating program, for the fellowship they do with yourself, with Jacques Marcos, with others in pediatrics. Every single one of them has had nothing but positive reports back. They've moved on to amazing careers. So thank you very much. And I hope that we can continue in this collaboration to continue to train our graduates. It's really a positive experience for every single resident that we've sent to you as a fellow.
Yeah, the pipeline will continue both ways despite COVID, I'm sure.
That's right.
Dr. Zade, I just wanted to say hello. Nice to see
hi,
you.
Shelley.
Hi, how are you doing?
Very good, thank you. You look very nice as always. This has always been it's very nice to see you. Congratulations on your kids.
Oh, thank you so much. And on yours as well. You know, I think you are extremely well-spoken, very excellent talk, doing some really great job in Toronto. So we are so proud of you and so happy with the work that you're doing.
That's very kind of you, Shelley. Nice to see you.
Nice to see you. And I think I might be the only person in the audience who's had the pleasure of training with Dr. Zade as a resident. So I do remember doing my first pituitary adenoma with you and also my first ETV with you. So that's really great.
That's very nice. It's very nice to see you. Again, I wish that we were in person, but hopefully in the future.
Yes, yes, absolutely. And I guess since we're telling stories now, I'm going to tell a story of my first interaction with Dr. Zade, actually, when I was a first year medical student. I was actually in the operating room shadowing anesthesia as part of my rotation, and my anesthesiologist had subsequently fell asleep. So in Dr. Zade's OR. So, of course, I went to the other side and I watched a very nice tumor resection that she did and a spine case, which I think is actually a microdisc for a laminectomy. And that was my first interaction with neurosurgery. And I was hooked afterwards. And I continued to do a lot of neurosurgical shadowing. And then I became a neurosurgical resident. So I will credit that to you.
Well, I'm proud. Thank you, Shelley.
You have another talk, right? On
at 8 o'clock.
Yeah, I would say start earlier for sure, if there isn't any other questions.
Okay. I'm going to get the other talk. How are your COVID numbers currently?
They're actually getting a little better after the last couple of weeks. It's been interesting. You know, we really haven't stopped doing elective cases for maybe except for a week, even though the numbers are probably equally as bad as they were 6 months ago. We've kind of learned to integrate the two systems, but last 2 weeks, definitely better. I've traveled to Canada about 3 times in the last 6 months, and you can see that Canada is doing extremely well. I mean, especially the last time I went, it seemed very open, and getting through immigration was not a problem.
You came up for family reasons?
Yeah, my 98-year-old mother, I try to see her at least every few months.
Oh, that's sweet. That's very nice. Yeah, and actually, I think Doug Konzioka was saying that he has come up to Canada a few times to go to his cottage, and it's not been difficult or a cumbersome process for him either.
I hope he owns a testing center by now with the number of tests that he gets.
Yeah, our institution, which is University Health Network, where Toronto Western is perhaps a bit more restrictive than others. And in fact, we just passed a policy that if you're not doubly vaccinated as one of our healthcare workers, you won't be able to continue your position, which is has been met with some perhaps criticism, because I think you could continue to offer a fairly rigorous, safe standard, but leave some flexibility to the healthcare provider, and then offer them the option to do self-testing. But the majority wanted to make it fairly restrictive. I don't know what the status is in your institution and in general. What's the cultural acceptance of how aggressive to institute these rules?
I would say that they're moving towards that in the hospital situations, but it isn't up and running yet. But both at the university side and the hospital side, that's the discussion.
I see. Okay, so again, thank you very much for inviting me. And the continuation of my talk actually is to look at some of the translational work that we've done in the lab, particularly with regards to epigenomic signatures, and how, in my opinion, we have in fact impacted the change in guiding brain tumor management. Again, no disclosures. And once again, these are the tumors that we deal with in our neuro-oncology practice. What I'll show you in this talk focuses on the work that we've done on gliomas, recognizing that these are tumors that continue to challenge us. They evade therapy, and their prognosis, unfortunately, sadly for the patients and their loved ones, remains less than 18 to 20 months. And majority of the problem stems from the fact that although we see the mass on MRI, which is resectable, the area of what we refer to as perhaps edema T2 signal changes, which in my opinion reflects the invasion of the malignant cancer cells, is the challenge, in that there is a recurrence at the site and outside of the field. And understanding the patterns of invasion and identifying targeted therapeutics is where a lot of the research is focused. I would argue that in fact, when a patient presents with this lesion, already we've lost the battle, and we need to be better at predicting who will develop a lesion such as this so that we can intervene earlier. And hopefully some of the results I show you is moving us in that direction. Another set of results I want to show you, which is the biggest focus for my lab, is on meningiomas. And the incidence of meningiomas is increasing as the patient population is aging better. And so we need to better understand the biology and come up with therapeutics beyond surgical resection. We have a significant acoustic schwannoma practice. Our surgical resection, again, based on our Canadian practice, is really reserved to resecting tumors that are greater than 3 to 3.5 centimeter in diameter, with the remaining being treated primarily by gamma knife, which results in us really only operating on acoustic schwannomas when they're quite challenging. The current management paradigm for brain tumors in general, I would argue for all comers, is that the patient presents with a symptom, whether it's a focal neurological deficit or a seizure, and on rare occasions, it is coincidental for routine imaging where the patient is diagnosed. If the tumor is concerning on imaging, they move on to surgical resection right away. In some instances, we choose to continue surveillance imaging until the patient either becomes more symptomatic or there are features that are changed on the scans that are concerning, and we take them into the paradigm for surgical resection. Currently, the practice is following surgical resection. There is an approximately 1 week to 10 days wait till we get the histopathological diagnosis, and certain mutational patterns, in particular, again, relying on, as we were discussing, IDH mutation, 1p19q, MGMT for the glial tumors, and molecular markers currently for other tumor types in the adult population are not used to a clinical meaningful decision-making. Perhaps for pediatrics, of course, our medulloblastoma and ependymomas, the molecular signatures are more defining. They then go on to receive standard chemoradiation with very few options for chemo, relying heavily on temozolomide for most of our adult neuro-oncology population. And when they fail, they move on to clinical trials. And unfortunately, in the last decade, and I would perhaps even argue the last 2 decades, successful clinical trials have been quite limited. And this is the area that challenges us in the field of neuro-oncology for glioblastoma research and patient management. I wanted to focus first on meningiomas, however, and you could see that these are tumors that can occur anywhere in the craniospinal axis. There are tumors that are in the convexity. There are tumors that can be resected completely with very little residual and a generally accepted good outcome. But I'll show you some data on recurrence rates. And then there are tumors that are more challenging because they involve the cranial nerves, vasculature. And so sometimes leaving residual is an inevitability following surgery that would then require additional therapeutics. And once again, in the case of meningiomas, our often go-to is radiation, which is not the best option for our meningioma patient population because these are not malignant growths and the patients continue to live a full life and unfortunately have the consequences of long-term radiation effects. If we look at CBTRUS, which continues to collect data on incidence of brain tumors in the US, you could see that in fact, for all comers of brain tumors, meningiomas are the majority of brain tumors. They're 35.8%. If we remove the malignant brain tumors, so particularly the largest portion being glioblastomas, the benign brain tumors that remain, meningiomas are over 50% of the tumors. If you look at the incidence per decade of life of all brain tumors, meningiomas sharply increase at approximately 65 years of age. The remaining brain tumors comparatively stay flat in incidence. And so as the patient population ages and ages well, if we look at the map of the world for the population age 60 and over, the projection in 2050 based on the various regions is that majority of people are in fact going to age well and stay over 60, and hence the diagnosis of meningiomas becomes a more dominant feature in our neuro-oncology practice. And in particular, as you could see in North America, the numbers will be higher. We don't have a good understanding of meningioma biology, and as a consequence, the predictors that we use in our clinical practice are somewhat limited. Of course, we rely very heavily on WHO classification that classifies between grade 1, 2, and 3. The distinguishing features between a grade 2 and grade 3 are somewhat subjective, with the inter-observer variability being high, as reported by neuropathologists themselves, where it relies on the mitotic index with more than 4 mitosis per high power field versus more than 20 mitosis per 10 high power field, distinguishing grade 2 from grade 3. And this is a subjective metric. If we look at the histopathology, there's 18 different subtypes. Some of them are aesthetically pleasing under the microscope, but beyond that, they don't reflect the biology or perhaps the behavior of the tumor. And other than a few subtypes, the rhabdoid and the sarcomatous meningiomas, the other subtypes don't bear on outcome for the patient. The other metric that we use in our clinical practice is Simpson Grading, which continues to remain valid, though it was introduced in the era of CT scans by the surgeon Simpson, where gross total resection, whether it's grade 1, 2, or 3 resection, complete resection, including dura and bone, with near complete resection, versus partial resection and biopsy. Of course, gross total resection has a lower recurrence rate compared to subtotal resection, but again, a very crude metric. And we know that the WHO and the Simpson grade, though important in our decision-making for recurrence rates, is not precise and accurate, because if we look at our own institutional experience, for grade 1 meningiomas, there's a wide range of recurrence. For grade 2 meningiomas, the range of recurrence, again, is quite broad. And these are the groups that challenge us the most and remain controversial as to whether they should have radiation post-resection or not for the residual or for the complete resected, the tumor cavity. And grade 3 meningiomas, where we assume they're all aggressive, some of them, in fact, have a very, very low recurrence rate. So what is it beyond the factors that we have studied or we use in our clinical practice that can speak to the recurrence rate and biology of this tumor? We were speaking earlier with Michael in his question about the pituitary tumors. And in meningiomas, if you look at the mutational pattern, and these are based on 2 Nature publications almost 20 years ago, where they looked at a large number of meningiomas, 600 grade 1, 270 grade 2, and 15 grade 3, a smaller number for sure because of the lower incidence. You could see that, interestingly, the mutation of NF2 is present consistently and at a high percentage in grade 1, 2, and 3. NF2, however, is a very big gene, difficult to manipulate, and certainly very difficult to find therapeutic targets against. The other recurrent mutations that we could see, the TRAF, AKT, smoothen, PI3 kinase, etc., the recurring mutations only occur in grade 1, interestingly, with the same mutations not evident in grade 2 nor grade 3. So in fact, there is no one single recurrent mutation that defines the meningiomas and distinguishes them in particular with regards to their aggressiveness and behavior. And so in my opinion, this is not a mutational driven tumor, but rather something else that drives the aggressiveness of the tumor. If you look at copy number alterations, not dissimilar to what I showed you from pituitaries, with increasing grade of meningiomas, there's more genomic disruption with more copy number losses in the higher grades compared to lower grade. However, you could argue that the distinction between grade 3 and grade 2, in particular as the numbers are small, are not significantly different. So are there other factors that could help us determine outcome for meningioma patients and, more importantly, be able to classify them more accurately beyond the WHO grading, which relies simply on the distinction between mitosis, brain invasion, and hypervascularity necrosis, and focus on something outside of mutational pattern and expression pattern? This again is showing you the methylation paper that was published in Nature in 2018 by the DKFZ group, which has really changed the way we manage brain tumors. And it shows that each of the methylation signature is very distinct for any tumor that you analyze based on methylation. A glioblastoma wild type and a glioblastoma IDH mutant have a very distinct methylation signature. We talked about the pituitary tumors, though they are clumped together and have a more proximate methylation pattern, they are distinguished depending on the functional status of the tumor again. So can we use methylation to understand meningiomas better? One of our earlier studies in 2017 was collaborative between the MD Anderson group and University of Toronto, where the test set, the first training set, was from MD Anderson of meningiomas analyzed by methylation. And you could see very clearly on the heat map that there are two distinct methylation subtypes, and each of them have a very distinct outcome. And so it can be predictive, perhaps, that methylation signature independent of grade of meningiomas on the outcome of the patient. These results were validated in a comparable number of meningiomas from the University of Toronto, where again, we see two distinct methylation patterns, with the blue having a more favorable outcome and the red having a poor outcome. So telling us that methylation signatures can in fact help predict the outcome for meningiomas and the recurrence rate. At the same time that we were doing the study, the DKF did a similar study. Their methylation patterns distinguished 6 different subtypes. And as majority of the clustering analysis goes, depending on the number of probes you look and the pattern of clustering, you may or may not get different combination and different results. And so I would argue, though they have 6 subtypes, really they have the benign tumors that have a comparable outcome. They have the malignant tumors that have a very poor outcome and an intermediate. So similarly, supporting both studies, each other's results, that methylation does distinguish outcome of meningiomas. And within each group of the methylation classes, there are distinct mutational patterns with, for example, the benign methylation group 3 having no mutational patterns, and the traditional recognized mutations that I showed you earlier falling mainly within the benign grade 2. Copy number alterations, as you could see, vary based on the group as well, and so on and so forth. They also tried to correlate the 18 different histological subtypes that I showed you to some of the methylation divided categories, and there doesn't seem to be a significant correlation, with only the anaplastic and atypical, which is primarily defined by the grade, falling within the last 2 categories of methylation. So we thought, if there's such a strong differentiation between meningiomas based on the methylation pattern, can we in fact leverage that methylome signature to predict individual patients' outcome? Because on an individual basis, these curves somewhat become meaningless because we don't know where me as an individual with a meningioma fall on this curve. We took a cohort of tumors and divided them into grades 1, 2, and 3 and looked at their outcome. And you could see, as predicted, grade 1s do better, grade 2s are intermediate, grade 3s are poor outcome. The same cohort of patients we analyzed by methylation, and independent of who grading, you could see that the methylation can predict outcome with a group that do very well, an intermediate, and a group that do very poorly. However, these two do not correlate, saying to us that the methylation predictor perhaps has a different mechanism of distinguishing the same cohort of tumors. So we then identified the probes that defined the 3 different subtypes of meningiomas and used those probes to our advantage to be able to come up with a nomogram, or a predictor of outcome for 5-year recurrence-free survival for meningiomas. We took a test set of approximately 230 tumors and analyzed them by methylation and identified an approximate 9,500 probes that were differentially methylated between these different tumors. We used this methylation probes that are distinguishing to create a pipeline and come up with a bioinformatic modeling that can then determine which of the subclasses of methylation the tumor falls into if you were to give it a random meningioma methylation signature. And we were then able to come up with a methylome-based predictor. We validated this in 2 cohorts and subsequently in a 3rd cohort, in fact, to respond to our reviewers. And we were able to validate that, in fact, the bioinformatic modeling, the machine learning algorithms, if you would like to call it, that come up with determining the outcome for that particular tumor is valid and reproducible and stable. We then layered on top of the methylation predictor clinical factors such as WHO grading, Simpson grading, gender, age, extent of involvement on MR imaging, and image characteristics, and really only a certain number of imaging characteristics, patient characteristics demonstrated a significance, and those were combined to create the nomogram. Based on the nomogram, if you look at the grade of meningiomas, so if we look at all WHO grade 1 meningiomas, you could see that majority of them have a very good 5-year recurrent-free survival. However, there is a subtype and a subpopulation of meningiomas that, based on the predictor, will do poorly. And again, in our clinical practice, we all have meningiomas that were called grade 1, but behaved aggressively. Grade 2, which, as I mentioned, are the most controversial meningiomas, and we often have debates as to whether they should have radiation post-resection or not, because they're considered to be pre-aggressive, pre-malignant, anaplastic. They divide based on the methylation predictor into 3 groups. One group that does very well, and I would argue that this group could then have a surveillance pattern of monitoring and not go on to radiation. A group that is intermediate in outcome, warranting further discussion at tumor boards and decision-making with regards to radiation. And the third group that do in fact act very poorly, and I would argue perhaps this is the group that you would safely recommend radiation. And currently, the pattern of thinking that I just explained to you for our WHO grade 2 is the model that we follow in our brain tumor boards on a weekly basis. We use methylation to guide our decision-making in who to receive radiation and who to withhold radiation, to avoid the consequences and adverse events of radiation, in particular in long term. In the WHO grade 3 meningiomas, where we are always told they behave aggressively, but again, in all of our clinical practice, we have grade 3 meningiomas that have good outcomes. You could see that the methylation predictor, in fact, pulls out those that will behave well and not aggressively. And I would argue again that this population could have radiation withheld more safely and in fact move on to a closer surveillance monitoring as opposed to having radiation. The remaining, the methylation shows, have poor outcome, whether they're the intermediate or the poor outcome group, and perhaps an upfront radiation strategy should be considered. So how does the nomogram work? It's 100 points on its score. The the WHO grading has a weight of approximately 50 in the calculator. And in a hypothetical situation, the WHO grade 2 gives you a score of approximately 25. The Simpson grade has a weight of approximately 20 out of the 100 points. And in a hypothetical case, if the patient had a Simpson grade 3, you get a score of about 10. And then the methylome predictor, which is the bioinformatic modeling that we have devised in our lab, and the predictor really relies on the methylation as it's a 1 to 100%. Once the methylation is done, we analyze the methylome predictor based on the probes that we've analyzed, and that gives us 60 points. Cumulatively, the total points come to approximately 90. On the 5-year predictive scale, this gives us a 0.4 score, and the inverse of that, so a 60% chance of recurrence at 5 years. And I would say that this tumor is intermediate, requires discussion at tumor boards, whether we would withhold radiation or not for this grade 2 meningiomas. This predictor was published in Neuro-Oncology. It's work done by one of the PhD students in my lab, who's a neurosurgery resident, Farshad Nasiri. The authors that follow all contributed to this study. And now we use the methylation predictor in our laboratory on a regular basis, as I mentioned, to make decisions as to whether or not patient would receive radiation or patient would go into a surveillance monitoring plan. The next set of data I want to show you is we do analysis by DNA methylation. We do analysis of tumors by RNA sequencing, by copy number, and by mutational patterns. And again, much like the question that Michael asked me about the pituitary tumors, the question remains which one of these genomic platforms that we have now really adopted in our research approach to brain tumors is the best platform to use to understand the tumors, to classify the tumors. Well, if we look at the same cohort of meningiomas, including grade 1 to 3 aggressive behaving tumors, invasive tumors on meningiomas, we could see that if we do RNA analysis, expression analysis, you could divide the tumors into 6 different categories based on outcome. You could see 6 distinct clusters. These are unsupervised clusters that are stable based on the number of probes that you use and are reproducible. And each of them have 6 distinct outcomes. And so you would argue that perhaps you could use a similar pattern based on expression analysis, as I showed you for DNA methylation analysis. DNA methylation analysis of the same cohort produces, once again, 6 different classes or subclasses of the tumor cohort. And once again, the 6 have very distinct outcomes. If we look at copy number alterations, again, we see 6 distinct stable clusters that have 6 distinct outcomes. And so the question really remains, which of these platforms are more accurate for us to use in clinical practice to guide decision-making, to understand the patient's tumor biology, and be able to counsel them and make decisions following surgical resection, or potentially for patients who have not had resection, but we can detect their methylation signature in the plasma, be able to judge the aggressiveness of the tumor's behavior. These are the platforms that I showed you: methylation with 6 different clusters, RNA with 6 different clusters, and copy number with 6. You then ask those that fall into cluster 2 of the copy number variation, are they the same as those that fall into cluster 2 of the RNA and those of 2 in the methylation? These are t-SNE plots that already tell you that probably the answer is no. And this is a plot that shows you the case that falls within the top line based on methylation crosses over to a middle bar in the RNA and crosses over further into copy numbers. So the amount of overlap 1-to-1 of one sample reflecting the same subtype based on copy number, RNA, and methylation is almost close to 0. So as you could see, the cluster that's here perhaps has some crossover to here, however, none to methylation. So the next model is, and a bioinformatica evolution in what we've done with our tumors, is to use a method called cluster of clusters. So the RNA clustering, the methylation, and the copy number clustering, how do we combine all of them into a single analysis of the different data sets to better understand the tumors and see whether we can come up with a more stable, more accurate, and more relevant biologically and clinical cohort division for meningiomas. The cluster of cluster or COCA analysis for the same cohort that I showed you, combining the different data sets, the methylation, RNA, and copy number, produces 4 distinct meningioma subtypes. This is independent of the WHO grade of the tumors, because you could see that the WHO grade, in fact, is scattered throughout, independent of meningioma grade, meningioma group 1, group 2, group 3, and group 4. They're also independent of extent of resection, which perhaps you could argue sometimes reflects the biology of the tumor. They're independent of the age and other factors that we considered in our multivariate analysis. The cluster of clusters is stable in that if you give it a number of other tumor types, it can reproduce the same 4 groups. If you look at the mutation pattern, which we've talked about, of these 4 different groups, MG2, MG1, MG4, and MG3, you could see that in fact, the recurrent mutations are, as previous literature has suggested, NF2 only, with some of the groups having a dominant NF2 mutation and some having very few NF mutations. The ones that are traditional reported previously, the AKT, smoothen, PI3 kinase, etc., are dominant within MG1 group, however, not recurrent again nor present in other groups. A new mutation that we found through our analysis is a PTEN mutation that ultimately only really has bearing within one group of meningiomas and possibly a therapeutic advantage that we can leverage there. We then looked at the expression pattern. So at the RNA level, at these same 4 groups of meningiomas, and interestingly, the patterns of RNA expression divide themselves and define themselves into patterns of biological pathways that define that group. So the MG1 group, for example, based on the COCA analysis, results in expression of genes that make that tumor more immunogenic compared to the MG4, the 4th COCA group, where the pathways define themselves as more cell cycle dependent and proliferative. And MG3 is more hypermetabolic, with the pathways defined that reflect more of a metabolic signature and involvement with metabolic pathways. MG2 has more of an angiogenic profile. And so there's biological relevance to each of these 4 groups, which again are stable. And as a consequence, perhaps you could argue we would understand the biology better. And were we to design clinical trials moving forward, you would argue that if you're looking at immune therapy, instead of having all meningiomas enrolled in an immune therapy trial, which then results in failure, unfortunately, you could potentially only target those that are immunogenic and demonstrate that immunotherapy works on this subpopulation of the tumor. Much like we discussed in the last talk, that the biology of the tumor perhaps will reflect, as precision medicine dictates, the directed therapeutics for that subtype. You would then argue also perhaps that the hyperproliferative MG4 class do better with cell cycle inhibitors and other agents that target the proliferation pathway. When you do an RNA pathway analysis, you can also do a drug screen associated with it. And in so doing, we were able to identify that for the MG4 class of meningiomas, a compound called vorinostat is effective in blocking majority of the nodes in its expression pathway. And so therefore arguing that if you are an MG4 meningiomas, perhaps you would benefit from vorinostat, where if you fall within the other categories, you would not benefit. So this is a review and summary that shows up as figure 1 of our paper and shows again what I showed you as the data, the 4 distinct meningioma classes with distinct outcomes, with MG1 having the best outcome, MG4 having the worst outcome. And again, remember MG4 were the hypermetabolic, the MG2 and MG3 having intermediate and distinct biological relevance. We also looked at prediction capabilities and power of predicting outcomes based on the 4 different groups. Much like the nomogram, you can create curves that can predict the individual patient's outcomes based on the subtype that you fall into. So next we ask, well, if we define these tumors based on these genomic platforms, can they actually be applied into clinical practice? That is the biggest rate limiting factor from what we do in the laboratory to what we can then translate into clinical practice. A way around this and a way to approach this is to take the same cohort of tumors that I showed you for meningiomas and analyze them by proteomics. This is the first comprehensive proteomic analysis of meningiomas. These are proteins overall between group 1, 2, 3, and 4 based on the COCA groups. And you could see that each of the groups are defined very distinctly by a subset of proteins. And those that could be tested in the laboratory by immunohistochemistry, in other words, there are existing antibodies that can capture the signature proteins that define each of the groups, are highlighted in red. And so S100 only stains MG1 tumors and not the other 3 groups. SCGN, again, an antibody that's readily available in clinical practice, stains only the MG2. The next antibody only stains MG3, and MCM2 only stains the meningioma group 4 tumors. So in other words, we've shown that there are distinct proteins that we can use as targets by antibody staining, by immunohistochemistry, to distinguish the genomically characterized MG1 to MG4 COCA groups of meningiomas, converting a very rich genomic data set, perhaps you would argue prohibitive genomic analysis for a patient's meningioma, into a very readily testable and analyzed immunohistochemical stain that could be done readily in any immunohistochemical staining in any neuropathology department, and allow us to add onto WHO classification the MG classification based on the staining that we could see here. And you could see the accuracy with which each of the stains can distinguish one subtype from the other, with the AUCs all being over 80%. The next set of data that we created was, as you recall, I showed you the RNA pathway analysis, and vorinostat was one of the compounds that emerged as those that are effective against MG4 group. And so we tested this in vitro and in vivo. We took tumors from each of the groups, MG1, MG2, MG3, and MG4, created them as cell lines to grow in a dish, and subsequently implanted them in the mice to grow as intracranial xenografts. And you could see that if you test vorinostat, of all the different cell lines, it really targets the one cell line that the RNA pathway analysis showed it will be effective against. Similarly, if we then test that one cell line, which is the MG4, the proliferative, vorinostat compared to vehicle control has a greater reduction in tumor growth and the volume on xenografts based on MR imaging, and also confirmed in subcutaneous animal models as well. And then the survival is significantly improved again with vorinostat. So confirming in preclinical models of a PDX of meningioma, which is very difficult and another rate limiting factor in our research for meningiomas, that in fact vorinostat could be considered as a compound that would then be effective against the MG4 subclass. So I would then propose to you that should I design a clinical trial, I would do this in a precision medicine manner in which the trial determines the subtype, whether it's MG1, 2, or 3, 4 meningioma group based on the cluster of cluster analysis. And if they fall in MG4, I would then provide them with vorinostat and compare them to other meningiomas of the same group, perhaps not treated with vorinostat, to determine the efficacy, safety upfront, of course, and then the biological effect on the tumor and impact on tumor growth in a clinical trial setting. So in summary, I hope I've shown you that we are able to use cluster of cluster analysis, combining methylation, RNA, and copy number analysis to reproduce 4 stable meningioma groups that depend on the combination and the cluster of cluster analysis of the different data sets, and then able to equally use the protein abundance in each of the groups to convert the genomic information into ready applicable immunohistochemical methods so that this could be adopted throughout any neuropathology laboratory in any department that does neuro-oncology. And you could see that the meningioma group 1, 2, 3, and 4 have very distinct outcomes. This bears again on counseling of the patients, and hopefully there's been some compelling data in our preclinical studies to show that in fact, based on the different subtypes, we can design clinical trials using targeted therapeutics for each of them effectively. This was recently published, in fact, August of this year, 2021, in Nature. And again, I have to give credit to Farshad Nasiri, who is the neurosurgery resident and PhD student in my lab, and the bioinformatic team that works in my group, Jeff Liu, Vikas Patel, and Yasin Mamajan, for all of their hard work and able to put all of the data sets and all of the analysis together. While I understand the bioinformatic components of it, it's really not my expertise. However, we have the skill sets to bring all of the different areas of strength together into the study. I also want to put a thanks towards the International Consortium on Meningiomas, which is a consortium that I started and lead since 2016. We've grown and we include approximately 32 different sites, and studies such as this are made possible where we combine samples and we're able to create the cohorts that we need for studies such as this. And of course, I'd like to thank the funding agencies that help support this work, support our students through CIHR scholarships. The NREF has been very helpful to all of our residents for supporting their research. And to, again, thank all of my lab members and people who keep me sane while I'm at home doing all the work. And I'll stop here and thank you again for this opportunity. It's really been a pleasure to be able to see some of you virtually and interact with you. I'm happy to take questions.
Thanks again. That was another phenomenal talk. I appreciate it. I had a question about when you're doing the methylation for all of the tumors. Is that like, do you have it set up now where it's like a CLIA certified lab at the university that just does that and it's very uniform for all cancers? Or is it just something that your lab is doing specifically just for brain tumors and then you're interpreting the data yourself?
Yeah, that's a super good question, Michael. We've struggled with getting ministry funding to support methylation. And so majority of the methylation is covered by my lab currently. Our institution gives some funding to ensure that because it's such a strong program, we are sustained. In speaking to people such as Dr. Snuderl at NYU, Ken Aldapi at NCI, it's a bit different because NIH covers all of the fund or all of the work that they do. But in the States, similarly, it's challenging to have methylation covered. The question about it becoming a CLIA-approved lab, I think in the sites where they do use methylation, again, NYU, NIH that I know use this now on a regular basis, they do integrate it into their CLIA report. However, there's a bit of a disclaimer that's added in there, which we use the same language for ours when we report on our pathology reports as well. Having said that, it says something about the process of CLIA approval, or CAP, the American Association of Pathology approval, as to how we integrate new discoveries into clinical practice. Because as I mentioned, we have really, after some process of educating and having people recognize the value of methylation, now adopted accepting methylation as a main feature in helping with our diagnosis. And we've moved from a point where pathology, in particular radiation oncology, I don't know if any are in the audience, we're a bit suspicious, hesitant, reluctant, et cetera, whatever, about accepting the methylation results, to today, our radiation oncologists ask for the methylation signature, to help with comfort in understanding the aggressiveness of the tumor, the biology, the classification, and two, in decision-making. Because if it's a young patient, and I showed some of these results when last year I spoke in University of Miami, where of the challenging cases, about 80% have a change in diagnosis, challenging defined by two neuropathologists can't reach consensus. In all comers, there's a 15% change in diagnosis. So these are very compelling numbers and you can't argue against them. And over the years, we've demonstrated that the methylation is in fact accurate. And we are now in the process of comparing head-to-head histopathology with methylation in a prospective manner to see how accurate for all comers of tumors we can use methylation. And so we now have adopted it, and though it's not 100% CLIA approved, we use it in clinical practice with the disclaimer being written into the pathology report.
Great, thanks. And so you're doing it on all tumors now, not just...
Well, because of the finances of it, for a straightforward glioblastoma, which is clear that it's IDH wild type based on histopathology, we do not. But a glioblastoma that has suspicious features on imaging, or the surgeon feels that this didn't really behave like a glioblastoma, and I'm just using glioblastoma as an example, we definitely do methylation. A best example I would give you is we resected a periorbital lesion that came back as a metastatic adenocarcinoma. It just didn't feel to me like it was a metastatic lesion. And so we went back to methylation and went back to the histopathology and reclassified the tumor accurately.
So all your samples, you're just freezing them in tumor bank, and then if there's a question, you'll send it off for methylation, basically, is
Yes, but you know, the beauty of methylation is that it could be done on paraffin. So you only need 5 unstained cuts of the paraffin slide, and you extract DNA. And so you don't actually need frozen samples. You can use the banked or archival pathology tissue to do the analysis.
Awesome. Thank you.
And the methylation predictor that I showed you is now an online tool. So there's a website you can go to. Once you have the methylation, you can upload it and it will give you the predictive methylation score. And then if you enter Simpson grade and pathology grade, as I showed you, it will give you a 5-year recurrence score. And so it's readily available for using it broadly as much as you feel comfortable to adopt it.
If there's no other questions, I was going to maybe turn the tables a little bit on the questioning in the sense that, but before that, I just wanted to thank the brain tumor group for putting this lecture together through a generous donation of Curtis, one of Dr. Komatar's patients. I mean, it's fantastic to get internationally acclaimed surgeons talking about their experience. I know that you've been working on this and has some experience now with your residency program in terms of how you move residents along as in sort of a competency-based residency, which is like completely different than the US based residency, which is 7 years. Now it's going to be 6-1. But maybe can you tell us a little bit about that and how that is going? Because now you've got probably 5-6 years of experience in that realm.
Yeah, so that's a really good question, because we actually, although competence by design has been rolled out, neurosurgery were not uncommon in other areas, late adopters of it. So we're just actually starting with that process. The orthopedic team had the biggest experience, and they really speak very positively about the experience, and they are able to somehow expedite the transition of the residents through their training. As you might know, Nir Lipsman is the person I selected to be our residency program director. He and I have spent a lot of time talking about the values, the limitations, and how best to adopt the competency by design modules for our residents. I would say up to now, my experience is the ability to provide feedback on a more formal level, because sometimes the long case happens, issues happen throughout the case, not issues as a problem, but learning points that perhaps you're focused on the case and you're not able to actually discuss with the resident. Whereas the process of being able to fill out an EPA on the resident gives you that opportunity to provide more direct feedback, whether it's face-to-face or online, and it opens the dialogue for them to come back and want to explore, where they could do better, etc. The limitation comes for cases where the numbers are not that many. And so how would you then provide them with enough number of cases to have a graded improvement in their EPA? That's where I think the challenge is. And so, for example, on acoustic schwannomas, in a 6-month period where a resident's assigned to me for 3 months, the number of acoustics they're going to be able to do in a graded manner to independence is going to be limited. And so that becomes a little bit of the bottleneck of the value of competence by design. But for routine general neurosurgery, I think it's very good because it allows you to achieve that competence, and perhaps it tailors to the strength of that resident. And at the Royal College level, we're now discussing whether we would actually then allow residents to write their exam earlier. Because as you know, in Canada, we have to write the exam before we go into practice. And so if you've progressed through your EPAs and you've achieved those, you don't have to go through a standard 6 years, and you might be able to go a bit earlier to write your exam. That's the area of, that's where we're discussing it right now. There's pros and cons to that. I think sometimes also the gap is much like generational gap. There's an apprenticeship that we have, that we've learned in our training and then impart it to our residents and fellows. And that component is a little bit difficult to measure and put in an EPA. So sometimes watching somebody operate under a microscope, at least in my experience, it's difficult to quantify it into an EPA and the competence metrics that we use. But the advantages of it are, it does tailor where you focus your training of the individual, and there's more objective metrics as opposed to a general feeling that they've now improved and gone on to the next year. And sometimes you, as you know, you may complete your 6+1 or 7 years of training and be very strong, and sometimes you may not have actually reached a level where you could be independent and competent. So this gives you a little bit of a tool or a strategy to be able to tailor it to the individual trainee.
Thanks. Dominique, did you have a question?
I did, yeah. Hey, Dr. Zade, good to see you again. Great talk.
Nice to see you.
I had a question about the cell lines you created. I think that's awesome and a good way to kind of advance some of these studies on meningiomas. Do you see preservation of the methylation status and the kind of clustering that you have from the native tissue with the cells that have been in culture over time, or from the in vivo studies?
Yeah, that's an excellent question. I didn't show all of the data of the paper just for interest of time, but what we did is we took agnostic, and we didn't obviously know the grade or the COCA grade of the meningiomas in advance, but we cultured all the cell lines. And as you know, one of the biggest barriers for meningioma research is we don't have great models. The cell lines don't last. The existing cell lines have been overpassaged so much that some of them, in fact, are not meningiomas. And then the cell lines, as they survived and we continued to replicate them, we did methylation analysis on them, and to ensure that they're meningiomas. So the existing meningioma cell lines that are commonly seen in literature and research laboratories, Ioma Lee, CH5, etc., a few of them, in fact, based on the methylation classification, do not classify to meningioma. And when the classifier doesn't know what it is, it calls it choroid, or it says unknown. And so Ioma Lee, in fact, comes out as unknown. It's not meningioma. These cell lines, we made sure that the classifier with high accuracy and the predictive score on the classifier was meningiomas. And then next, we looked at the methylation to see how it aligns to the MG groups, and did the expression analysis on the cells as well. Because as you saw, the COCA analysis is based on expression, methylation, copy number. We use copy number to derive, methylation to derive copy number. And so we picked the lines that matched with MG1, 2, 3, and 4. So the fear, of course, on my part is that we lose these lines as you passage them. But so far, we've been able to maintain them, and they grow well in vivo. And the histopathology of the tumors that grow intracranially are meningiomas, and the methylation of those tumors are also meningiomas. And they're available if people would like to use them for research. Yeah.
Perfect.
Nice to see you again.
You too.
Okay, it sounds like that's everything. That'll conclude this morning. Thanks so much. I think the residents will meet you later on today to discuss some cases, and we appreciate your time. Thank you so much, and hope to see you in person soon.
Thank you. And again,
thank you so much,
congratulations
Gelareh.
for these great series. Thank you. Thank you, Carolina. Nice to see everybody. Bye-bye.